Let's start by the retinal vascular disorders. So first of all, what is meant by retinal vascular disease? Retinal vascular diseases are a part of generalized systemic vascular diseases. So this is one of the very common mistakes that maybe an ophthalmologist will do, that he will say, or he would check a patient eye and neglect the patient's underlying systemic condition. So please remember, a retinal vascular disease is not as specific to the retina. It is just a part of underlying systemic vascular disease. That's why this patient need checkup. This patient need to referral, needs to be managed in accordance with other subspecialties or other specialties with the internist or the cardiologist and others. So don't ever forget that the retinal vascular diseases needs to work up, or the key word here is to do work up for the patient to know what will be the underlying systemic condition. Let's start by the first one, which is the most important, is the diabetic retinopathy. In all vascular diseases, epidemiology is very important and one of the hot topics that are asked in the exams. So starting by the diabetic retinopathy, it is the leading cause of preventable blindness in the developed world, in the Western countries, but not in every age group, but in the adults of working age group. So in the working population, the diabetic retinopathy is the commonest cause of blindness in the Western countries. So who are what is the commonest cause of blindness in Western countries in the older age group, and those who are older than working age? It will be the age-related macular degeneration, which will be covered the next time. The diabetic retinopathy affects all genders, all races. However, the African Americans are more frequently affected and more severely affected than Caucasian. So this is another thing that is specific to African Americans. Remember the primary open-angle glaucoma, and now we are talking about diabetic retinopathy. African Americans are more affected. There is a difference between the incidence and rate of progression in diabetic retinopathy between type 1 and type 2. So type 1, as you know, in type 1, those are insulin dependent. So it is unlikely that you will find the diabetic retinopathy at the onset of diagnosis, even within the first 5 years. Because since that he is insulin dependent, he needs insulin. And since, so you know exactly at what point did he got the diabetes. And diabetic retinopathy needs time to develop. So type 1 will not develop until 5 years. 5 years. In this case, he will be like 25% of patients with type 1 diabetes will have diabetic retinopathy. However, the rate of progression will be very high, as in 20 years, the incidence will be almost 100%. So there will be high incidence of progression. This is more serious. Unlike type 2, so type 2 could be present like for 10 years or 15 years unnoticed, undiagnosed, and he has underlying pathology that is progressing, causing diabetic retinopathy. So in many occasions, those patients are discovered accidentally. So we don't have an accurate estimate what will be the after 5 years or after 15 years, but 20% of type 2 diabetes will show signs of diabetic retinopathy at diagnosis. So 20%, unlike the type 1, 20% will show signs of diabetic retinopathy at the onset of diagnosis. And at 20 years, it will be less incidence of progression. It will be like 60% of those patients will have signs of diabetic retinopathy, depending, of course, on the control. Okay, so when should or when will the type 1 develop proliferative changes, and when will the type 2 will develop proliferative changes? So proliferative changes or proliferative diabetic retinopathy, such as neovascular glaucoma, tractional retinal detachment, vitreous hemorrhage, all these are more common in type 1. As I told you, it will have more tendency to progress. So 50% of patients will develop PDR in 20 years in type 1, while 25% of patients will develop PDR in 25 years in type 2. Also, what will be the commonest cause of loss of vision in type 1? So as we told, it will not, those patients may not be presenting unless they present with complications like proliferative diabetic retinopathy, like the patient suddenly developed vitreous hemorrhage or tractional retinal detachment, and so on. Type 2 will present more commonly with macular edema. Okay, so this will be the commonest cause of loss of vision. So we said here, as you can see, that the duration matters here. The duration is the most important risk factor. What are other risk factors that can be suggestive of diabetic retinopathy progression? For the second most important will be the poor control of diabetes. So diabetic control should be will be one of the most important things that we should pay attention to in those patients. Also, pregnancy and hypertension tend to aggravate and increase the progression of diabetic retinopathy, neuropathy as well, and some other vasculopathic risk factors such as hyperlipidemia, smoking, cataract, surgery, obesity, and anemia. So why the diabetic retinopathy happens? Let's see what is the pathogenesis. We can summarize the pathogenesis of diabetic retinopathy into two words: occlusion and leakage. So why there is occlusion and why there is leakage? This is a diagram representing the arterioles and the capillaries and the venules. So there will be occlusion of the capillaries. Why this happens? This is because of that the glucose will cause, or the hyperglycemia present in the blood will cause basement membrane thickening. This membrane is basement membrane thickening. Also, with the glycation of the endothelial cells, the glucose will cause endothelial cell damage. This thickening of the basement membrane and the endothelial cell damage will make the surface of the blood, or surface, the inner surface of the blood vessel is not smooth. It will be rough. So there will be a rough surface that will result in RBCs changes. It will make the platelet aggregate on this RBC in this rough surface, leading to thrombus formation, leading to occlusion by thrombus. Okay, so this is because of the rough surface of the inner wall of the capillaries caused by the damage that happened because of the blood glucose. Also, the blood glucose will cause not only the damage to the basement membrane, but also it will cause loss of pericytes. Pericytes are the cells which are lining the blood vessels. It will line the capillary endothelium. So if there is lost pericytes, there will be gaps. These gaps will result in leakage of the vascular content. So any vascular contents will be leaked out from the blood vessel wall. So eventually, the consequences of the occlusion, it will result in ischemia. So there is occlusion. This occlusion will result in that this area supplied by this occluded blood vessel is ischemic. So as a compensatory mechanism, the retina will develop, the blood vessels will try to develop an anastomotic shunt or arteriovenous shunts. Okay, so this will be one of the earliest mechanisms to overcome this hypoxia or this ischemia. The second mechanism is that the blood vessels will try to overcome this ischemia by secreting a vasoformative substance, or a material that will increase the vessel formation. It is called VEGF, or vascular endothelial growth factor. This vascular endothelial growth factor, the retina thinks that it is something helpful to revascularize the retina, to nourish the retina. So it secretes the VEGF. However, the retina doesn't understand that these VEGF are harmful. Why? Because this VEGF will induce formation of abnormal blood vessels, what we call neovascularization. This neovascularization is what will be responsible for the diabetic complications. So these abnormal blood vessels will result in neovascularization at any part of the retina present on the optic disc, leading to what's called proliferative diabetic retinopathy, and will also cause neovascularization on the iris or rubeosis, leading to neovascular glaucoma. So this is what will be a consequence of retinal ischemia, which will be then neovascularization. What about the leakage? What will be the consequences of the chronic leakage? So we said that there will be lost vessel wall, there will be lost endothelial cells or lost pericytes. This will result in leakage. So this leakage will result in leakage of blood from the blood vessel wall, leading to retinal hemorrhage. It will also lead to leakage of plasma proteins, resulting in retinal edema. It will also lead to leakage of lipids, plasma lipids, resulting in hard exudates. So the hard exudates, the hemorrhage, and the lipids or the retinal edema are all consequences of the chronic leakage caused by the damage of wall of the blood vessel. Okay. Okay, so this is the mechanism of diabetic retinopathy. What will be the classification? How would we classify the diabetic retinopathy? It is also a common mistake to just say it is a diabetic retinopathy without talking about the maculopathy, or classifying the maculopathy without stating the state or mentioning the state of diabetic retinopathy. So in general, we should always comment on the diabetic retinopathy and in maculopathy. For diabetic retinopathy, it can be either non-proliferative or proliferative or advanced diabetic disease, or there is a stage of complications. The non-proliferative will be classified into mild NPDR, moderate NPDR, or severe NPDR. In proliferative, it will be early APDR or high-risk PDR. And finally, the advanced diabetic disease, in which there is a stage of complications. The maculopathy can be classified into either macular edema or macular ischemia, or combination of both in mixed maculopathy. Macular edema can be either focal diabetic macular edema or diffuse diabetic macular edema, or cystoid or clinically significant macular edema. So let's explore what is meant by these terms. Non-proliferative diabetic retinopathy is the earliest stages of diabetic retinopathy, in which there is changes in the retina, but with no new vascularization. There is no abnormal blood vessels. To classify it, there is a famous study called the Early Treatment of Diabetic Retinopathy study that classified the diabetic retinopathy into in the non-proliferative diabetic retinopathy into mild and moderate and severe, depending on the rule called the 4-2-1 rule. What is meant by 4-2-1 rule? Meaning that if there is hemorrhage in the 4 quadrants of the retina, this is called a severe NPDR. If there is venous beading meaning that there is a segmentation of the veins like that in 2 quadrants, this is a case of severe NPDR. If there is ERMA in 1 quadrant, which is called ERMA, meaning that it is intraretinal microvascular abnormalities like shunt vessels, intraretinal microvascular abnormalities. This is meaning that in 1 quadrant, this is sufficient to deem it as a severe NPDR. So if a patient has any one of these criteria, hemorrhage in 4 quadrants, venous beading in 2 quadrants, intraretinal microvascular abnormalities in 1 quadrant, he is called severe NPDR. If there is none of the above, there is nothing of this criteria, like this patient, just only microaneurysms, which will be the earliest sign of diabetic retinopathy, it will be called mild NPDR. Let's just stop or disable the annotation. Okay, so if there is no signs of any of the above, it is called mild NPDR. If there is venous bleeding or hemorrhage or microaneurysm, but less than the above criteria, like this patient, you can see that there are some flame-shaped hemorrhage. These are called hard exudates. There is dot on the blood hemorrhage, but they don't fulfill the 4-to-1 rule. So in this case, we call it like a severe NPDR or a moderate NPDR. If there is any of the above, like this patient, for example, they have hemorrhage in 4 quadrants, and then this is called a severe NPDR. And this patient who has ERMA or intraretinal microvascular abnormalities, then this is called a severe NPDR. So this is called NPDR, and it will be the earliest stages. After that, if the patient is not controlled, he will develop a severe MPDR or proliferative diabetic retinopathy. So severe proliferative diabetic retinopathy, in which the retina is starting to show some complications. It's like new vascularization. New vascularization on the disc is called NVD, like that. So this is a response of occlusion and ischemia and secretion of VEGF. Or it can be new vessels elsewhere. If it is not present on the disc, it will be called NVE or new vessels elsewhere. Or if it is present on the iris, it will be called new vascularization on the iris. Or it can present with advanced cases where there is vitreous hemorrhage or pre-retinal hemorrhage. According to the studies, it will show the high-risk PDR in which there is more tendency to develop complications. And according to the study's criteria, it will be if there is new vascularization on the disc which measures more than 1/4 of the disc diameter, or if there is a new vascularization over the disc of less than 1/4 but associated with vitreous hemorrhage or pre-retinal hemorrhage, or if there's new vascularization elsewhere more than half of disc diameter, meaning that measuring more than half of the size of the disc, or if it is measuring less than half of the size of the disc with vitreous hemorrhage or pre-retinal hemorrhage. Advanced diabetic disease, meaning that the patient is progressing to more serious complications like rubeosis iridis and neovascular glaucoma, or tractional retinal detachment, or hemorrhage such as subhyaloid hemorrhage or pre-retinal hemorrhage. So these are different forms and kinds of proliferative diabetic retinopathy. So this will be one thing or one classification, which is what are the stages of non-proliferative and proliferative diabetic retinopathy. The other thing is the maculopathy. So maculopathy, let's start first by the macular edema. So the macular edema, it has two main pathologies. Either it is due to dilated capillaries. So we said that the capillaries are damaged. There will be leakage from these damaged capillaries because of the damage of their wall. So this will result in edema in the retina and also result in exudation. So this will be one pathology or one mechanism which will be responsible for diffuse macular edema. So diffuse macular edema, it is due to dilated capillaries and defect in the wall of the capillaries, resulting in this swelling of the retina and exudation. The other mechanism is when there is leaking microaneurysm. So if there is leaking microaneurysm, then this microaneurysm will cause leakage because of the defect of this microaneurysm, which will be responsible for focal edema. So focal edema, it is due to leaking microaneurysm, and diffuse edema will be due to damaged dilated capillaries. So how do they look like? This is the maculopathy, a focal diabetic macular edema. So there will be like what's called cercination meaning that this pattern of hard exudates, which will denote that there is a leaking microaneurysm in the center. And when doing fluorescein angiography, we can see that this cercinate is corresponding to area of hyperfluorescence leakage in the fluorescein angiography. When the leakage doesn't have a specific location or it is present all over the macula, this is a diffuse diabetic macular edema. The leakage is everywhere in the macula. So this is due to dilated capillaries and defect in the capillary wall. So this will be one pathology or one kind of maculopathy. The other kind is called ischemic maculopathy. In ischemic maculopathy, those patients will have dropped visual acuity, but with very few signs in the fundus. You can see the fundus will show just few hemorrhages. They are away from the fovea, but like you can see that this patient has like visual acuity of 660, and you don't have any explanation why the patient doesn't have such poor visual acuity. And the response will be, or the answer will be revealed when you do fluorescein angiography. So in the fluorescein angiography, you will find that if you remember this blackish area of the fovea, it will be very enlarged. It will be very irregular. So this is enlarged irregular foveal avascular zone. which should be devoid of blood vessels, and it becoming very large, very irregular, and this means that there is ischemia in the macula. And you remember, this is the absence of vascular tissue. This is what was one of the causes of hypofluorescence. So there is increasing in the hypofluorescence in the foveal avascular zone, meaning that there is ischemia in the macula. Or the patient could present with both conditions, like it will be both mixed maculopathy. There is both edema showing hyperfluorescence and also showing increasing the hypofluorescence of the foveal avascular zone or enlarged irregular phase, denoting the presence of ischemic maculopathy. So it will be combination of both. There is another, we won't say a classification, but we will say it is a term. This term was described in the early treatment diabetic retinopathy study, or ETDRS, which was one of the landmark studies in the diabetic retinopathy, and doesn't have a high significance nowadays, but it is asked in the exams. So in the maculopathy, there is a term called clinically significant macular edema. This clinically significant macular edema, what is the definitions or what are the criteria of the clinically significant macular edema? We measure it by disc diameters. So the disc diameters, as we know, it is 1,500 microns. So if we are measuring anything within the fundus, we compare it by the disc size. It will be like one disc diameter, meaning that it is 1,500 microns in both dimensions. So the clinically significant macular edema can be either one of three definitions. It could be if there is any retinal edema within 500 microns from the center of the fovea. So this circle within 500 microns from the center of the fovea, if there is any edema involving it, it is called the clinically significant macular edema. Or if there is hardly exists within 500 microns from the center of the fovea, with adjacent retinal thickening. So this adjacent retinal thickening doesn't have to be within the 500 microns, but here the hard exits are within 500 microns from the center of the fovea. And this is also termed as clinically significant macular edema. The third term is when there is retinal edema of one disc diameter or larger, any part of which will be within one disc diameter of the fovea. So one disc diameter of retinal edema, any part of which will be within one disc diameter of the center of the fovea. Okay, so these are the three definitions of the clinically significant macular edema. And why would we say, or why we study it, or why the ETDRS, the early treatment diabetic retinopathy study, stressed on this? Because it found that in those patients, when they receive macular grid laser or focal laser, this will decrease what's called moderate visual loss by 50%. So this is the significance. No, it is not a clinically significant, but it is just a statistical study that will show that those patients will benefit from macular laser, like either in the form of diffuse or grid laser or focal laser, and it will decrease the visual loss by 50%. Okay, but nowadays this term is no longer clinically significant, because we treat we treat the macular edema depending on two factors. First of all, the visual acuity, and the other will be whether it is involving the center or not involving the center. Okay, and also we consider and at that time when the ETRS was conducted, there were the anti-VEGF were not introduced like nowadays. So nowadays we depend on the anti-VEGF heavily for management of these cases. And speaking about the management, we will be a little bit confused whether to which road should we take. First of all, whatever the modality of treatment that you are going to do for your patient, don't forget the diabetic control. So diabetic control will be the first thing to do to keep the hemoglobin A1C, the glycosylated hemoglobin, below 7. And then you manage according to the case. Like if the patient visual loss is caused by focal leakage due to microaneurysm, so do just a focal laser on this microaneurysm. If it is outside the center, it is not involving the center. Or if there is like diffuse leakage, then macular grid laser will be an option. If there is new vascularization, then the management will be through the pan-retinal photocoagulation to do laser to the retinal periphery outside the arcades, from outside the arcades to the periphery. If there is macular edema, then the treatment should be anti-VEGF or steroids. If the patient develops some complications like vitreous hemorrhage or the tractional retinal detachment, then them can be managed by parsoplanal vitrectomy. But so parsoplanal vitrectomy is not indicated for everyone, but if the vitreous hemorrhage is severe and non-clearing for 1 year, but it can be done. The trend now is to be done for earlier cases if there is traction retinal detachment, or if the patient has type 1 diabetes, or if the other eye has like a poor vision from previous diabetic complications, or if it is there is premacular hemorrhage, as this hemorrhage can cause some fibrosis over the macula. So those will be, or if there is a tractional rhegmatogenous retinal detachment, this will also be an indication for parsoplanal vitrectomy. Another also important thing is, okay, so I know the patient, how would I treat the patient, but what will be the regimen of follow-up? The regimen of follow-up depends on the stage of the patient. Like if the patient doesn't have any problems, like if he is just a diabetic patient, but doesn't show any signs of diabetic retinopathy, there is no signs of macular edema, so just examine every 1 to 2 years. If there is mild non-proliferative diabetic retinopathy, examine every year. Moderate non-proliferative diabetic retinopathy every 6 months. Severe non-proliferative diabetic retinopathy every 3 months or less than 3 months. If there is proliferative diabetic retinopathy, you should give him laser or do pan-retinal photocoagulation and examine in less than 1 month. Okay, so we spoke about the let's talk more details about the treatment modalities, like the anti-VEGF. What is meant by the anti-VEGF? They are molecules, synthetic molecules that are injected intravitreally in order to combat or to counteract the effect of the VEGF on the eye, so it will minimize the new vascularization. So there are 3 forms of the anti-VEGF, like, so there are other forms which are recently discovered, but this is for the exam. For the anti-VEGF, so we have 3 forms: the aflibercept 2 milligram, or what's called Eylea, the bevacizumab 1.25 milligram, or Avastin, the ranibizumab 0.5 milligram, or Lucentis. So regarding the FDA approval, the aflibercept and the ranibizumab only the FDA approved, while the bevacizumab is an off-label drug. What is the mechanism of each one? The aflibercept is a recombinant fusion protein that binds to VEGF-A, VEGF-B, and placental growth factor, which makes it the most powerful. So aflibercept is the most powerful, as it will combine to VEGF-A, VEGF-B, and the placental growth factor, and that's why also it can be given every 2 months. Doesn't have to be given every month. Bevacizumab, or the Avastin, it is originally an antineoplastic drug which was given to patients with cancer colon, and it was found that those patients showed improvement of age-related macular degeneration, and that's why it is now can be used as an off-label drug. So it wasn't introduced originally for the eye, but it was given for, as I told you, for the cancer colon. It is a complete anti-VEGF body. And the ranibizumab, or Lucentis, it is a humanized monoclonal antibody fragment that binds to VEGF-A. Okay. These are the anti-VEGFs which are given for the new vascularization and also can be given for macular edema. There are other previous drugs that were used before the invention of the anti-VEGF to the macular edema, the steroids. But the steroids are their use is now limited for cases which are not responsive to the anti-VEGF, and because of their hazards, they can cause rise of the intraocular pressure, can cause cataract. So just the different modes of or different drugs that can be used for injection into the eye are triamcinolone acetate. So as we said the last time, it will be having 50% risk of increasing the intraocular pressure. So it will be reserved and also the cataract. So it will be reserved mainly for cases which are pseudophakic. Dexamethasone implant or Ozurdex, which will be for cases who are not responsive to the triamcinolone acetate. Another steroid as a slow release implant is called the fluocinolone acetonide implant or Elovine. This also can be used as an alternative to the Ozurdex. So these are the drugs or the anti-VEGF. We will speak mainly about the anti-VEGF. The anti-VEGF, what will be the regimen? How should they be given? For whether for diabetic macular edema or for choroidal neovascularization, it will be the same regimen. It will be a monthly injection for 3 months in CNV and 6 and 4, and monthly injection for 6 months in diabetic macular edema. Okay, why the 6 months? Even if the patient show improvement in the first or second month, there still should be continuous for 6 months because of the half-life of the microaneurysms. They will be like 6 months, so that if we are just giving them for 1 or 2 months, the microaneurysms will still be there, producing more edema. Okay, so will be the duration. However, it should be given monthly, but as I told you, the aflibercept or the aflibercept can be given every 2 months, or the Eylea. So the aflibercept or the Eylea can be given only every 2 months. Then after that, we will tailor our treatment according to the response using one of the 3 regimens. It can be either monthly treatment. So if the patient is still needing the injection, we can still giving him monthly injection as a fixed treatment regimen. So the advantage of the monthly regimen that it will show rapid response, rapid improvement of the visual acuity, and the gain is maintained at least for 3 years. But as you know, the disadvantage is the financial cost and also the higher risk of endophthalmitis. There is another regimen called the PRN treatment. The PRN is not giving the patient every month, but it is giving the patient when needed or as needed. So when we check the patient at clinic, we find there are signs of macular edema, we do OCT scanning, find the edema, then we inject. So if there is edema, we inject. If there is no edema, no injection. The third regimen will combine the advantages of both regimens, like monthly treatment and the PRN treatment. It's called treat and extend. In treat and extend, the regimen, we will just we will, as the like monthly injection, like monthly regimen, the patient will receive monthly intravitreal injection. However, it is instead of the 4 weeks interval, instead of the fixed time between the first injection and second injection, we will just increase or decrease the interval between injections depending on the response. So let's say, for example, if the patient received an injection and he showed a good response, so I don't need to inject him after 4 weeks as in monthly time, but I will just extend. I will inject now and extend, like after 6 weeks. After 6 weeks, I'm seeing that the patient is improving. So I will give him another injection after 6 weeks and extend the follow-up after 8 weeks. Let's say, for example, after 8 weeks, I found that the patient is worsening. So I inject and follow him again after 4 weeks. So I will tailor the duration between follow-ups depending on the patient's response. Okay. So this is called the treat and extend. Let me show you some nice flow charts by our medical retina expert, Dr. Amin Marashi. So this will be like, how would we think of a case of a patient with a diabetic retinopathy depending on the fluorescein angiography? So if we find a hyperfluorescence, it could be either in the macula due to leaking microaneurysms. So if it is non-central, we can treat it by focal laser. If it is central, we treat it by anti-VEGF. Okay, if there is increase in the central macular thickness confirmed by the OCT. Hyperfluorescence also can be in the retinal periphery, and this is mostly either new vascularization elsewhere or new vascularization on the disc, and in this case should be treated by pan-retinal photocoagulation. And if there is intraretinal microabnormalities, then we should do tight glycemic control, because those patients are at a higher risk to develop progressive diabetic retinopathy, or do PRP in high-risk patients, like those patients who show non-compliance or lost other eye from diabetic complications. Those should be managed by PRP. If there is hypofluorescence in the macula, then this means that it is irregular or enlarged foveal avascular zone, which means that the patient has ischemic maculopathy, which indicates a poor prognosis. So no treatment usually, it is just a supplements. Or if the hypofluorescence is present in the retinal periphery, which means that it is hypoperfusion of the retina caused by ischemia, meaning that those patients needs a pan-retinal photocoagulation. So this will be the how would we manage the the diabetic patients depending on the fluorescein angiography. Also, the OCT will have a very important role. So it is not, we don't manage a patient with the fluorescein angiography alone or OCT alone. Both of them complement each other. Both of them are essential for making a diagnosis and formulate the plan of management. For the OCT in diabetic macular edema, we should, it has a very essential rule to exclude the presence of vitreomacular traction. So if there is vitreomacular adhesions or vitreomacular traction, if this is present, yes. So if there is any cystic changes within the macular thickness, then the cystic changes denoting the presence of microaneurysmal leakage. So we treat by the anti-VEGF or steroid. If there is focal attachment of the inner retina with the macular thickening, then those patients are unlikely to benefit from injection. They should be treated by partial vitrectomy with or without internal limiting membrane peeling. And if the first group of patients didn't show improvement, then we can do partial vitrectomy. If there is no vitreomacular adhesion, no traction over the macula, then we should localize the presence of where is the edema. If it is central, so the treatment should be, we cannot do laser to the fovea, of course. So we just give injection by anti-VEGF or steroids. If it is non-central, then we can treat by focal or grid laser. The OCT also can show what's called drill. Drill is the disorganization of the inner retinal layer. So if there is disorganization of retinal inner layers, or if there is an ellipsoid with or without internal limiting membrane disruption, if it is present, then unlikely that this patient will benefit from the treatment. But we give it anyway, but we just, this for prognosis. It will show guard prognosis if there is disorganization of the retinal layers. If there is no disorganization of inner retinal layers, then it will show good visual prognosis. Okay. So this is for the diabetic retinopathy. I hope that it is clear. I know that we took some time in it, but it is important. So that's why I wanted to put more details about it. Let's now move to the next topic, which is also the second one in importance, which is the retinal vein occlusion. So retinal vein occlusion, when there is occlusion of the veins, what will be the pathogenesis and the clinical features? The pathogenesis, when there is venous occlusion, there will be stagnation. So there will be the venous blood will be stagnated, leading to elevation of venous and the capillary pressure. So this will result in the stagnation of the blood flow, and this will stagnation. The blood vessels or the blood will be present within the dilated vein, so the blood will not go anywhere. This will result in retinal hypoxia. The blood will not go anywhere, so this will result in hypoxia. This hypoxia will result in damage to the capillary endothelial cells. So the damage to the capillary endothelial cells will result in the same mechanism like in diabetes. It will cause edema, it will cause leakage. The contents of the blood will go out of the blood vessel because of the damage to the wall, resulting in edema and hemorrhage. What happens after edema and hemorrhage? The edema and hemorrhage will be outside the wall. So they will compress on the wall of the blood vessel from outside, resulting in increasing extravascular pressure, leading to more obstruction, more stagnation, and the vicious circle will continue. So this is what will happen in the venous occlusion. What will be the clinical features of retinal vein occlusion? It will be present with dilated tortuous veins, present with retinal hemorrhage, and the edema. It will be also engorgement of the optic disc by the venous blood, also present with macular edema, which will be one of the causes of loss of vision in those patients, and also presence of the cotton wool spots. What will be the presentation? It can be present with, if there is obstruction of the branch of retinal vein. So we have the central retinal vein will be divided into upper temporal, upper nasal, lower temporal, lower nasal. Let's see here, there is here obstruction of the upper temporal branch retinal vein, resulting in hemorrhage, edema, distributed with the distribution of the upper temporal branch retinal vein. Also, it can be a central retinal vein occlusion. So central retinal vein occlusion will be, there will be widespread hemorrhages all over the fundus with dilated tortuous veins, as you can see here, and optic disc edema. Okay, you can see also that there is another pathology here, which is you see this this area, this pale area in the center. This is occlusion of the cilioretinal artery. So the pathology here is dual, is double. The pathology causing central retinal vein occlusion together with occlusion of the central retinal artery. Also, the occlusion or the venous occlusion can only involve the macular vein. So there will be macular vein occlusion resulting in hemorrhage with the distribution, which takes the distribution of the macular vein. So what will be the causes of loss of vision? As I told you, the macular edema will be one of the causes. Also, if the patient developed a new vascularization from the ischemia, as I told you, there will be ischemia. So it could be this ischemia will result in vascularization, and this new vascularization will result in new vessels which can bleed, leading to vitreous hemorrhage. And then the patient will be present with macular edema, vitreous hemorrhage. And what is the most important thing to be afraid of here is the development of neovascular glaucoma. So neovascular glaucoma will be one of the feared complications of the ischemia in those patients. That's why those patients need to be followed up periodically. So as I told you, in patients with diabetes, they need workup. We need to know what is the blood glucose level and the presence of any risk factors. And the same thing for every case, for any diabetes, for any retinal vascular disease. But the important thing here in the vein occlusion, there are some general screening tests that we should do for all patients with vein occlusion, like blood pressure, blood glucose, ESR, C-reactive protein, CBC, coagulation profile, lipid profile, and ECG. However, for young patients, we are more thinking of not a vasculopathic risk factors, but for risk factors of thrombosis. Those patients could have hypercoagulable state. So we need to do workup of the hypercoagulability. Like the patients could have, we should check for the homocysteine level. Autoantibodies, like the patient could have vasculitis. This vasculitis is what's causing thrombosis. Remember the Behçet disease causing the ischemic vasculitis? So this patient, we should check for rheumatoid factor, anti-nuclear antibody, anti-DNA, ANCA. thrombophilia screen, such as all the hypercoagulable materials that can be present in those patients, like protein C, protein S, anticardiolipin antibody, antiphospholipid antibody, lupus anticoagulant, and antithrombin 3. Also, chest X-ray angiotensin converting enzyme for sarcoidosis, fluorescent troponemal antibodies for syphilis. This should be also checked for patients who are young and develop vein occlusion. So as I told you, or as you may hear, that there is the retinal vein occlusion can be either of non-ischemic type or ischemic type. So non-ischemic is the present is will be present before the development of new vascularization. In the ischemic, there will be new vascularization, which will result in ischemia. So what will be the difference between the non-ischemic and ischemic? So in the non-ischemic, there will be dilated tortuous retinal veins in all four quadrants with retinal hemorrhages and optic disc edema, as we just mentioned. But in the ischemic, there will be have more serious manifestations. The ischemia will result in high drop of the visual acuity, maybe less than counting finger, and this drop will be associated with relative afferent pupillary defect with deep hemorrhages and cotton wool spots. In the non-ischemic, there will be signs. If the patient is non-ischemic and develop chronicity, he will show some disc collaterals, epiretinal gliosis, and pigmental changes at the macula. In the ischemic, it will show venous sheathing, resorption of the hemorrhage, macular pigmentation, and also collateral vessels at the disc. In the non-ischemic, there will be fundus fluorescein angiography can show delayed arteriovenous transit time, venous wall staining, microaneurysm, dilated disc capillaries, blocked fluorescence due to hemorrhage. But in the ischemic, it will show extra features, like it could show capillary dropout, and sometimes it can be more than 10 disc diameters of the significant ischemia. Leakage, such as which denotes the cystoid macular edema or the new vessels. So the presence of leakage in non-ischemic denotes cystoid macular edema or edema. In the ischemic, it will denote either edema or new vascularization. In the non-ischemic, the prognosis is related to the initial visual acuity. So if it is less 618 or better, it will improve. If less than 660, it will unlikely to improve. However, in the ischemic, it will be also have poor visual acuity, but the optociliary chance is sometimes they can develop optociliary chance as a result of ischemia, and this optociliary chance will protect the eye from anterior segment new vascularization. Regarding the recovery, so the non-ischemic will, for 15% of cases, will progress to the ischemic in 4 months, or 34% in 3 years. That's why we need to follow up those patients for development of ischemia and the new vascularization. The ischemic will progress to reduce eye radius 37% within 4 months. And if more than 25% of the retina is non-perfused on the fluorescein angiography, they can develop glaucoma, what's called 100-day glaucoma. So those patients will develop glaucoma within 100 days. The non-ischemic complications is cystoid macular edema, and for the ischemic, it will show more range of complications that will affect the vision, like cystoid macular edema, new vascularization on the iris or on the disc or elsewhere, new vascular glaucoma, and very poor prognosis from macular ischemia. So what will be the treatment plan? How should we treat a patient with a retinal vein occlusion? Again, starting by workup. Workup for especially if a young patient for vasculitis screen and for other systemic diseases, autoimmune diseases. And then the treatment is depending on the presentation and the presence of sight-threatening complications. Like the treatment modalities can be either observation or anti-VEGF or the laser. So let's see. Like if the patient has non-ischemic vein occlusion with very good visual acuity, like 6.6 or 6.9, and you did OCT and the fluorescein angiography, so there is no macular edema. Does it happen? Yes, it happens a lot. So the patient has a vein occlusion just a hemorrhage with no edema, with good visual acuity because of like the hemorrhage is away from the center of vision or away from the fovea. So just for observation with follow-up every month for 6 months. And if at any point, if there is macular edema developed by fluorescein or OCT, then you treat as the second group. Of course, with the systemic workup and antiplatelet therapy in order to, especially if the patient has vasculitis or any systemic risk factor. The non-ischemic, if the patient developed poor visual acuity like 612 to 660 with the fluorescein angiography and OCT showing macular edema, in this case, we do anti-VEGF injection every 3 months and follow up with the OCT. And if there is after 3 months, there is no response, then we shift to another anti-VEGF. If there is no response, we shift to intravitreal dexamethasone implant. If there is no response, we shift to macular laser. Again, follow up with to find any signs of rubiosis and any signs of ischemia. If there is any signs of rubiosis or a presence of new vascularization, we do sector PRP. Again, we do the PRP only with the development of new vessels. We don't do it prophylactic. Ischemic vein occlusion. If the patient has ischemic vein occlusion, and those patients will be unlikely to have a good visual acuity, so they will have poor visual acuity. Again, it will be intravitreal injection by the anti-VEGF and follow up every 4 weeks for 3 months. And then we do scatter laser photocoagulation in the areas of ischemia, avoiding area of retinal hemorrhage only after development of new vessels. And if there is vitreous hemorrhage, so we do paraplanar vitrectomy. Like this, for example, this patient, you can see the widespread hemorrhages in the fundus. So this patient has a central retinal vein occlusion. And you can clearly see that here there is a plugged fluorescence here in the fluorescein angiography. But you can see that there is leakage. And this leakage is confirmed by the OCT scan, showing cystoid macular edema in the OCT scan. So this means that there is a cystic spaces within the retina. And these cystic spaces will denote the presence of edema. It is hyporeflective. And so this means that in the early stages of the vein occlusion, the OCT will be more valuable than the fluorescein. So if you have just a question in the exam, which will be more valuable in the at the onset of the vein occlusion, it will be the OCT. It will show the presence of edema, which will give us which will enlighten us to know whether to inject or not. But in the late of the course of the disease, the more valuable or the fluorescein angiography will regain its importance because it will show us the new vascularization and it will show us the ischemia. So every investigation has its rule. The OCT will quantitate the amount of edema, and while the fluorescein angiography will show the presence of ischemia and new vascularization. So for those patients, this patient is a candidate for just anti-VEGF injection because of the edema and it is involving the center. If the patient has ischemia and this ischemia result in new vascularization, so you can see here in the fluorescein angiography, this is an area of ischemia, and this area of ischemia is more than 5 disc diameter. So what shall we do? According to the branch retinal vein occlusion study, it said that you don't do the scatter laser photocoagulation over the ischemic area unless there is new vascularization. So if there is ischemia more than 5 disc diameter, wait for the development of new vascularization. So you just do close follow-up. Once you see new vessels, you do PRP. So you may wonder why we just don't do prophylactic laser in order to prevent the development of new vessels. So let me tell you why. Because first of all, it was found that the prophylactic laser does not prevent the occurrence of new vessels. So laser is just for treatment, not for prophylaxis. The second thing that the laser has its complications. The laser can cause a visual field defect. And also the third thing is that if you do laser and there is no new vessels, what will you do when the patient develop new vessels? You will find no place in the retina to shoot your laser. This is especially more for cases with central retinal vein occlusion. This is will be more valid. So you will just preserve the retina, spaces in the retina for development of new vessels in order to shot your laser. So this is a result of the branch retinal vein occlusion study. Also, there is a central retinal vein occlusion study. Central retinal vein occlusion study has the same conclusion, which also, if patient has new ischemic retinal vein occlusion, ischemic central retinal vein occlusion with areas of capillary dropout and non-perfusion, if it is more than 10 disc diameter, not 5 like in branch, but it is 10 disc diameters, wait for development of new vessels. Once there is development of new vessels, then you do a PRP or pan retinal photocoagulation. So you just do the laser outside the arcades, all over the retina, outside the arcades, only leaving the macula in order to burn the ischemic retina so that you will prevent that new vessels from occurring and prevent new vascular glaucoma and vitreous hemorrhage and other complications. Okay, so that's it for the vein occlusion. Let's now move to the third disease, which is the retinal artery occlusion.